I'm going to talk to you about RVUs. Do they really measure the workload and complexity of what we do? The short answer is not really, but we'll talk a little bit about that. So there's been increasing use of productivity-based compensation models, especially for employed physicians. Can I ask by a show of hands, how many people in the audience are on a productivity-based compensation models, RVU-based or otherwise? Yeah, and I think what we're doing is we're seeing that increasingly in academics as well. And you can see the numbers are here about what dollars per RVU. And again, this is in funds flow in academic institutions is becoming increasingly common. As a matter of history, Congress reformed how physicians were compensated for services under Medicare in the late 1980s. Shao and a group of researchers, Harvard researchers with input from different specialties for HCFA, which is part of HHS responsible for Medicare and Medicaid services, developed what is called a resource-based relative value scale intended to reflect the cost to deliver each service in medicine. So they developed this relative value of every single one of the thousands of services provided by doctors, a job that was later described as measuring the exact amount of anger in the world. For example, Shao's team deemed that a hysterectomy required 3.8 times more mental effort and 4.5 times more technical skill than a psychotherapy session. The current system includes three components: work, practice expense, and professional liability, with final payments incorporating a geographic adjustment and a conversion factor determined annually to accommodate budget constraints. So this is kind of how it's done. The initial work RVUs for urology were created by a technical consulting group of 3 urologists nominated by the AUA and the AMA, which looked at 405 codes, CPT codes, and selected what they deemed was the most important 22. They then administered telephone surveys to a national random sample of 115 urologists to rate pre-service, intra-service, and post-service work for these codes. The remaining 383 codes were determined, the work was determined in a similar fashion, surveying 2 panels of 14 urologists nominated by the AUA. So for these surveys, again, each component of work was defined as the product of time in minutes and the intensity of the work to develop, what was termed as work. A combination of technical skill and physical effort, mental effort, judgment, and stress. And this is actually the original kind of description of the different pre, intra, and post work. Using this work data for different CPT codes, relative assessments of work were made by starting with a reference service assigned a standard work value for 100 units, which for urology was an ambulatory diagnostic cystoscopy in a man with microhematuria, which was determined as 100, then rating all the work of the other services based on this. For each specialty, the technical consulting group, a cross-specialty panel was formed with the Harvard researchers to determine the service across different specialties that required the same amount of work, and again, develop this resource value scale. Initial RVU assessments were made with nominees from the medical specialties, but there is the ability to, on a quarterly basis, to modify this. And it's mainly based, I'll show you here in a second, on survey data. So for each, and ultimately, these financial constraints mean that this is a zero-sum game, because increasing the value of one set of RVUs has to decrease it for another. So for any specialty society to propose a change into a CPT code, so if we all want to increase it for this code or not, the specialty society has to come up with a survey, a summary of recommendations form, often based on survey data from the members. This is typically 50 or 75 surveys. They try to get at least 100, but it can be as low as 50, which then is then reviewed by this RUC, Relative Value Update Committee, which is 30 physicians, 8 of them are surgeons, 1 is a urologist. and then they can make recommendations to CMS, which typically rubber stamps this based on the recommendations. But again, remember, because of budget constraints, if you increase it for urology for a specific CPT code, it has to be decreased for orthopedic surgery or another specialty. So again, it's a zero-sum game. So who gets the surveys? You can see here respondents from AUA random sampling. So when they send out the survey, it could be subspecialty or general, private practice, academic, hospital-based. You need at least kind of 30 to 50 responses. So it doesn't take much to change it. The real issue is that RUC committee. So given the fact that RVUs are becoming a common measure of productivity and compensation, there's really a question of whether they truly are an objective measure of the surgical complexity and workload. Is it a good currency of the work and difficulty of what we do? So there has been some correlation in hepatic, vascular, and plastic surgery, and some with op-time in pediatric surgery, but not in general surgery. So the question that we wanted to ask is, what about urology? So what we did is we took 5 years of NISQIP data, 56 urology-specific CPT codes that were felt to evaluate the spectrum of urology, and the main outcome variables were op-time, length of stay, morbidity, mortality, adverse events, readmission, indirect measures of our effort. And then we wanted to also see what are the outlying procedures. So we excluded non-elective as well as concurrent CPT codes and ended up with about 190,000 cases. The relative values of the 56 CPT codes range from 4.6 for a small TURBT to 44 for a radical cystectomy. So what we found is that you can see here that RVU correlated fairly well with length of stay as a group, OR time, and morbidity. However, there was only moderate correlation with things like mortality and unplanned readmission. We did find some outlying findings as well. So this is length of stay, for example. Here the outliers are lap partial nephrectomy, which for a length of stay of 2 had RVUs of 27, so it was disproportionately higher. This is OR time, a true measure of our work. Here you see a couple of codes. RPLND, only 17 or 18 RVUs for the work that's put in, and as well as epididymovasostomy, a low amount of RVUs for the work done. Here is morbidity. You see lap partial nephrectomy and ureteral reimplant with disproportionately higher RVUs. And then lastly, when you look at mortality, there were no outliers, probably because mortality in our field is relatively low. And lastly, adverse events or complications. Again, higher RVUs for the amount of complications for pyeloplasty and lap partial. And then lastly, readmission. You see here reimplant with ureteral tailoring, relatively low RVUs for the amount of readmissions. So this is the RVU values, the R-squared correlation. So what we did is we tried to build a multivariable model with this. And what we found from this and with regard to outliers is that RPLND, lap partial nephrectomy, lap ureteroneocystotomy, and cystectomy may benefit from reevaluation. RPLND would have a projected, in this multivariable model, variable model should have an increase in about 11 RVUs due to the median operative time of 256 minutes. Cystectomy, also an increase of about 6.5 RVUs. Lap ureteral reimplantation, a decrease of about 7, and lap partial nephrectomy, a decrease of about 7 RVUs. To summarize, contrary to what our hypothesis, there is a generally, for our field, fairly good correlation with OR time and length of stay and morbidity, not so good correlation with mortality, readmissions, and SAEs. There are some important outliers to be considered. Considering these events occur predominantly within the 90-day global period, it may not be consistently account for all of the work that is done, resulting in readmission or mortality. And it's important to realize also that, to kind of finish up on this concept, the importance of the wRVU should measure the work that we do. And I think we probably need to move away from subjective assessment to objective measures and look at things over a 90-day or longer period. It doesn't include RVUs, also measures of quality or cost of care, and perhaps there should be an element of that in there. And consistent, I think, within the specialty and across specialties. I want to do a quick, in closing, comparison with other specialties. So you can see here, this is op time and length of stay, and you can see urology in blue. And a few outliers here positively. Cardiac surgery, for every 1 hour increase in procedure, there's 27 more RVUs. Same with neurosurgery and orthopedics, as well as in length of stay, there's benefits. And here is kind of negatively for, on the lower end, urology and thoracic don't get the benefits of increased OR time, and orthopedics with length of stay. So this is how the op time looks. Again, cardiac surgery shifted up. And this is some of the other factors with urology, positively in readmission rates for ENT and gynecology. Serious adverse events, morbidity, all benefiting gynecology, ENT. Negative for these, you can see in these other areas too. So there's not a consistency amongst specialties. And again, I think ultimately, as I mentioned before, I think we need to, if these are going to be used as our currency and our payment, they need to adequately reflect the work that we do and the complications and the op time and the effort that we put into that. And as I mentioned, I think should include issues like quality of care, cost of care. Let me show you here. And this is, if we do a subjective or objective way of evaluating this in a multivariable model, we can actually come up with an equation, an objective equation of how we do this to calculate RVUs. I think rather than asking people subjectively by a survey, what do you think the effort of this is? I think there is an ability, and again, this QIP isn't perfect, but it's something more objective than what we currently have.